This is Selma Schimmel, and you are looking live at the great city of Chicago, which is once again playing host to the American Society of Clinical Oncology, ASCO. This is ASCO's 49th annual meeting, and this year's theme could not be more appropriate: Building Bridges to Conquer Cancer. More than 30,000 of the world's foremost cancer specialists are here, and so is the Group Room, making our 15th appearance at ASCO and one of our very best. Joining me now is Dr. Thomas Smith, Harry J. Duffey Family Professor of Palliative Medicine and Oncology at Johns Hopkins Medicine.
Thank you.
How do you juggle your time? When do you finalize certain affairs? And how do you really integrate all of this into your life in a way that's honest, realistic, not morbid, still hopeful, because we talked about hope being fluid. What you hope for at the beginning of a disease is different than what you hope for later on. But hope doesn't go away. Hope just changes. To me, the two most important words to this experience is acceptance and integration. Being able to integrate this into my life and being able to accept it. And it's such a simple word. But at least for me, I can't speak for other people, the ability to accept the circumstances. If you can't accept it, you can't cope. You have to accept it.
It's much easier if you can accept what's going to happen, and it's much easier if you have some idea of knowing what's going to happen, and that you've established a trust relationship with your healthcare professionals so that you can say, what's going to happen to me? And not get, well, everything will be fine, just don't concentrate on that. We still have multiple things that we can do. And the inner part of me is thinking, as a patient, what is going to happen to me? As you say, you're thinking about these things all the time.
It's very, very challenging for when other people will look at you and say, you have survived this so many times, you'll be fine.
You'll be fine. And it's a wonderful, well-meaning comment, but I wish oncologists would learn to say, tell me more. Maybe the three most important words in the English language, as opposed, so when you're saying, I'm worried about what's going to happen, they would say, oh, you'll be fine. Not. They would say, tell me more.
Well, the palliative care specialist, I learned that's the kind of discussion he will have.
Right.
The medical oncologist is going to look for, well, what's the next compound we can try? I have to say, well, you know, what is the value of my life if all I am living for is treatment?
Right.
I'd like to see myself and others look at quality of my life is measured literally by the quality of my days and my times and my ability to feel as good as I can. It cannot be measured by the quantity of days, because if those days aren't good days, if those days are just about living to take more treatment, then that's not quality at all.
Well, I don't know you well, but I would suspect that the disease and its treatment is not going to define who you are.
I don't think so.
What you really want is to be as alive as you can for as long as you can. And one of the so far cold, hard scientific facts about palliative and hospice care is that you can not only live better, you can probably live even longer if you pay attention to these things.
Well, that's the other point that I would love to drive home about palliative care, and that is that you can coexist using the best of what palliative medicine can give you, and at the same time, you can still be receiving treatment.
You can still do chemotherapy. I see people who get artificial hearts, left ventricular assist devices, and one of the things we found is that people do better when you have somebody paying attention to their pain, their shortness of breath, how they're coping, how their families are coping, making sure the chaplain is involved in the hospital. And that's curative intent treatment. And we're in there pitching to get people better. So I'm saying, look, you had your surgery yesterday and you haven't gotten your butt out of bed all day today. In order for you to get up and walk, you need to get your butt out of the bed, into the chair, and we're going to get the nurses and the physical therapists in to do that. That's a former coach in me. And if things don't go well, and somebody wakes up after getting an artificial heart and has a terrible coma, which happens, then you can explain to you can sit down with the husband and the 4 kids and say, remember we did talk about this, but that's why we did that 1-page worksheet that we call preparedness planning. So what's going to happen if your wife wakes up or doesn't wake up and she's in a coma? We wanted to make sure that your kids knew what was happening to her. We wanted to make sure we had a plan with the child life people for every eventuality. Wanted to make sure we had all the adoption and legal things in place. That's just good preparedness planning. So we're still hopeful that your wife can get better, but it may not be the same way. It's no different with cancer patients. When somebody has serious cancer, there is no harm to planning how things are going to go.
First, I want to say thank you.
Sorry?
I want to say thank you first.
You're welcome.
Dr. Thomas Smith, the Harry J. Duffey Family Professor of Palliative and Oncology Medicine at Johns Hopkins Medicine.
Thank you.
Thank you, Dr. Smith.